Om Swastiastu, Assalamualaikum warahmatullahi wabarakatuh, Shalom Namo Buddhaya. First, I would like to thank you to all participants. So we, SGD B3, could present our paper entitled Chronic Lympoblastic Leukemia. But let me introduce myself first. I am Indra Prabha Dewi, with the last two digits of my student numbers are 146. Here are the members of our SGD B3, and let's start with the paper's introduction. The problem formalism for this paper are shown on the screen. The purposes of this paper are shown on the screen. And the function of this literature review is to give proper information about chronic lymphoblastic leukemia. And this literature explains about the definition, epidemiology, etiology, pathophysiology, diagnosis, differential diagnosis, treatment, and prognosis of chronic lymphoblastic leukemia. We sincerely hope this literature can give a great insight about chronic lymphoblastic leukemia and will contribute to the improvement of the disease's knowledge and ultimately establish the way for improvements in treatment and improved quality of life for patients dealing with this disease. Chronic lymphoblastic leukemia is a slow-growing malignancy characterized by an increase in the generation of mature but defective B cells. Chronic lymphoblastic leukemia is a prevalent public health issue, accounting for 25 until 30% of all leukemias in the United States. The disease causes various manifestations, including fatigue, weight loss, enlarged lymph nodes, and recurrent infections.
Hello, doctor and friends. My name is Patricia and Jotan, and the last three digits of my student number is 171. Now I want to explain about the overview of chronic lymphoblastic leukemia. Leukemia is a broad category of hematologic malignancy that arises from the abnormal proliferation of leukocytes throughout their developmental stage. Leukemia is classified as a primary or secondary process depending on the development of abnormal leukocyte. Based on the rate of proliferation and the origin cell, it is categorized as a myelolytic or lymphocytic and either acute or chronic. For chronic lymphocytic leukemia, it is a rare type of cancer that affects the blood and bone marrow. The spleen, lymph nodes, bone marrow, and peripheral blood are the main illness sites. The indolent malignancy known as lymphocytic lymphoma, the small one, or SLL, or chronic lymphocytic leukemia CLL, is typified by a rise in the generation of mature but defective B cells. It usually develops very slowly and does not always need to be treated right away. CLL or SLL is a monoclonal lymphoproliferative disorder that appears as smudge cells on the peripheral blood smear and is defined by the development and accumulation of physically mature but immunologically defective B cells lymphocytes. It's not clear what caused chronic lymphocytic leukemia, but having a close family member who's had it may mean you have a slightly higher risk of getting it. CLL has a strong familial aggregation with 2 to 7-fold higher prevalence among family cluster than in the general population. That's all from me. The next slide will be explained by my friends. Thank you.
Let me introduce myself. My name is Bagus, Tresna, Indra, Putra, Pramana with the last three-digit number 104. And now I'll explain about the epidemiology of chronic lymphoblastic leukemia. The incidence of chronic lymphoblastic leukemia differs according to race and geographic region. Adults in the Western population are the most typically affected with chronic lymphoblastic leukemia. Among Jews of Eastern European ancestry, chronic lymphoblastic leukemia is prevalent. Asians experience it the least frequently, and non-Hispanic whites are the most frequently. African Americans' incidence falls between that of the Caucasian and Asian ethnic groupings. In the United States, chronic lymphoblastic leukemia accounts for 25 to 30% of all leukemia cases. This disease is thought to be the cause of 191,000 cases and 61,000 fatalities annually worldwide. Adults as young as 30 years old may be affected with chronic lymphoblastic leukemia, but the majority of those who experience it are adults with an average age of 70. Though children with chronic lymphoblastic leukemia are quite rare, it is well known that the incidence rises quickly with age. It is recognized that chronic lymphoblastic leukemia runs in families and that it has a genetic foundation. In comparison to the father, the second generation offspring's age of diagnosis is over 20 years younger, and siblings, kids, or parents of chronic lymphoblastic leukemia, patients have a double chance of developing the disease.
Thank you for the opportunity. My name is Putu Chandrika Rahma Dewi with the last 3 digit students number 071. So here I would like to continue to present about the etiology of chronic lymphoblastic leukemia. Chronic lymphoblastic leukemia, or CLL, is one of the hematologic diseases associated with genetic abnormalities that arise in the DNA of hematopoietic cells, which lead to the blood cells to create abnormal lymphocytes. A few known etiologies of CLL include tobacco smoking, radiation exposure, and occupational exposure to specific chemicals. Studies have shown a similar etiology to leukemia in general, such as a previous exposure to chemotherapy, exposure to ionizing radiations, exposure to benzene, a history of any hematologic malignancy, several genetic syndromes such as Down syndrome, and viral infections such as human T-cell leukemia virus. These cell lymphocytes are largely affected by the mutations, which are the specific cause of CLL, through chromosomal deletions, translocation, or extras. Large-scale cohorts of CLL demonstrate that the disease can frequently be brought on by the loss of insertions of significant quantity of chromosomal material, which can be followed later by other mutations that could intensify the leukemia. For example, the long arm chromosome 30q40, mir50A, and trisomy 12. Okay, that's all for me. For the next presenter, time is yours.
Allow me to introduce myself. My name is Yohanes with the last 3 digit number 089. In CLL, there is an issue with mature B cells, specifically CD5 B cells, causing them to overgrow in the bone marrow and lymph nodes. This happens slowly, leading to an asymptomatic phase initially. Over time, these cells increase in number and enter the blood, identified by a count of more than 5,000 per microliters for about 3 months. The mature lymphocytes formed in the bone marrow are ineffective, resulting in low antibody production, or known as hypogammaglobulinemia, making CLL patients prone to infections, particularly from certain encapsulated bacteria. Around 15% of CLL patients develop autoantibodies attacking their own red and platelet cells, causing autoimmune anemia and immune thrombocytic purpura. Elevated lymphocyte level trigger the release of pro-inflammatory cytokines, causing constitutional symptoms like fever and night sweats. BCL2, a protein preventing cell death, is abundant in CLL due to chromosomal deletion. Without regulation, these abnormal B cells continue to multiply, leading to lymphadenopathy. In some cases, this can transform into diffuse large B-cell lymphoma. The neoplastic B cells can infiltrate organs like the bone marrow, liver, and spleen, causing complications. In the bone marrow, overcrowding leading to decreased production of other blood cells, causing anemia, neutropenia, and thrombocytopenia. Infiltration in the spleen and liver result in hepatosplenomegaly, contributing to anemia and thrombocytopenia. This condition manifests in symptoms like fatigue, increased infection risk, bleeding, and abdominal discomfort.
My name is Patricia, Clarine, Simpson with the last 3 digit number 1 to 5, and now I'm going to talk about the clinical manifestations of chronic lymphocytic leukemia. Patients are usually asymptomatic when they first come in, but 5 to 10% of cases are symptomatic, with symptoms such as fever for over 2 weeks, unintentional weight loss for over 6 months, sweats at night with no evidence of infection, extreme fatigue, and early satiety. A routine CBC will reveal abnormal lymphocytosis, which can be a clear indication of CLL. 50 to 90% of patients will present with localized or generalized lymphadenopathy upon physical examination. On palpation, the nodes are firm, non-tender, round, and freely mobile. The common sites are cervical, supraclavicular, and axillary lymph nodes. The second most common and large lymphoid organ that is seen in 25 to 55% of cases is splenomegaly, which often leads to anemia and thrombocytopenia. Anemia will result in fatigue and shortness of breath, while thrombocytopenia will make the patient easily bleed and cause petechiae. Hepatomegaly is also seen in 15 to 25% of cases, and herpes zoster is also sometimes found in patients, mostly younger patients who require chemotherapy.
Hello, my name is Yanti Graciella with my last 3-digit number is 162. I will explain the next part. Histopathology and laboratory examination play a crucial role in diagnosing and understanding chronic lymphocytic leukemia. complete blood count or CBC is an initial test to evaluate hematological disorder. A complete blood count or CBC with differential in patient with CLL reveals absolute lymphocytosis with more than 5,000 lymphocytes per microliter. The most common laboratory abnormality associated with CLL is lymphocytosis in bone marrow and peripheral blood. Leukemic cells are visible in peripheral blood smear. Bone marrow biopsy show infiltration of lymphocytes in case with CLL.
Okay, hello everyone, my name is Putu Gita Nirajanari and the last 3 digits of my student number are 049. I'm here about to explain the treatment of chronic lymphocytic leukemia or CLL. So, for chronic lymphocytic leukemia patient, there are labels given to the patient according to the results of evaluation of their physical condition or comorbidities. Patient label GO are patients who have good physical condition or without comorbidities. Then patient with the label slow go are patients who have poor physical condition and or accompanied by comorbidities. The label refers to the indication of giving the type of combination treatment that is accordance with the patient condition. So as we can see here, we have two tables. For the first one is the table of first line therapy with the label go and slow go patient with a different combination of therapy. And then for the second line is used for the relapse case, which is have the label go and slow go also with different kinds of combination therapy. That's all from me. The next slide will be presented by my friend. Thank you.
Okay, hello doctor. Let me introduce myself. I'm Michael Jonathan Raya with your last digit student ID number 182. Now I'm going to explain about the complications of chronic lymphoblastic leukemia. So CLL could arise various complications. The cancer itself or the treatment for CLL is well known as the root cause of the complications. The susceptibility to infection is increased, especially in the respiratory tract due to inadequate production of immunoglobulin. And on top of that, they should not receive live vaccines as it could lead to further infection. CLL also leads to the progression of tissue large B-cell lymphoma, also known as Richter syndrome, a type of more aggressive cancer form. And the risk of further malignancies is also increased, like secondary cancers that might develop are skin cancers, particularly melanoma, lung cancer, and gastrointestinal tract cancer. And most CLL cases are also involved in the deviation of the immune system function, in which immune cells may mistakenly attack healthy cells known as autoimmune diseases. And that's all from me. Thank you.
Hello, my name is Wildan and my last name number is 174. So about the prognosis, patients with chronic lymphocytic leukemia have a survival range of 2 to 20 years with a median value of 10 years. After the diagnosis, 95% of CLL sufferers could survive within 1 year, 89.9% could survive within 3 years, and 84% survive within 5 years. The Raya staging and Binet staging are two staging systems that have been applied globally to assess the prognosis of CLL. The CLL sufferers with Raya stage 0 to 2 can survive 5 to 20 years without treatment. Meanwhile, in Binet staging, the risk group A had a 5-year survival rate of 88.7%. The group B has a survival rate of 79.9%, and then in the group C, the survival rate was 58.4%. The most recent and relevant prognostic factor is the CLL International Prognostic Index or CLL-IPI. The low risk category has survival rate of 93.2% without any treatment. The medium risk has the rate of 79.3% by giving treatment only when symptomatic. At high risk, the survival rate is 63.3% by giving treatment to patients unless they are asymptomatic. And at the very high risk, 23.3% is the survival rate with full treatment.
Hello, my name is Yanti Graciella with my last 3-digit IM number is 162. I will explain the next part. Differential diagnosis. Differential diagnosis that can be taken into consideration are acute lymphoblastic leukemia, acute promyelocytic leukemia, diffuse large B-cell lymphoma, follicular lymphoma, hairy cell leukemia, lymphoblastic lymphoma, mantle cell lymphoma, and non-Hodgkin lymphoma. Mantle cell lymphoma occurs because tissue cells produce protein causing CD5 to be positive. MCL generally consists of intermediate lymphocyte cells and centrocytes that have irregular nuclei. Sometimes this cell can also be small in size and look like chronic lymphoblastic leukemia. Studies report that some causes of MCL are weak for CD23, whereas CD23 expression is usually high. MCL that is positive for CD23 is often found to be similar to CLL. However, MCL has a better prognosis than CD23 negative patient. CD200 is a marker of CLL in the differential diagnosis with other CD5 positive lymphoma. However, according to the studies, about 4% of MCLs are found to be CD200 positive. CD200 positive MCL are indeed very similar to CLL or SLL. CLL and SLL are different manifestations of same disease. CLL is diagnosis if the disease is primarily nodal in nature, and CLL is diagnosis if the disease is found in the blood and bone marrow areas.
Hello, my name is Komang Mahottama with the last 3 digits of the number 221. The conclusion for our student project is Chronic Lympoblastic Leukemia or CLL is a rare type of cancer affecting the blood and bone marrow typified by a rise in the generation of mature but defective B cells. Nowadays, CLL accounts for 25 until 30% of all leukemia cases. The cause of CLL is not clear, but can be caused by genetic abnormalities that arise in the DNA of hematopoietic cells. The proliferation process tends to proceed slowly, so the lymphocytes be more mature and numerous, then enter the blood circulation. This is characterized by hypogammaglobulinemia. Patients with CLL are usually asymptomatic at first, but later then develop fever, unintentional weight loss, sweats at night, and others. The first-line treatment are FCR and venetoclax plus obinutuzumab or others, and the second-line treatment usually for patients with relapse situation. CLL can lead to several complications such as increased frequency and severity of infection and progression of tissue large B-cell lymphoma. The staging prognosis of CLL can be divided into 3 risk categories, namely low risk, intermediate risk, and high risk. The other differential diagnosis for CLL are acute lymphoblastic leukemia or ALL, acute promyelocytic leukemia, and others.
That's all the presentation of SGD B3. Thank you for listening.